Hi everybody and welcome to my channel. I'm Nadia and this is Patience and Patience, where I talk about motherhood, nursing, being the wife of a medical resident, life, and basically anything else that I want to talk about. In today's video, I'm going to be doing a video on how to give report like a boss. If you're a new grad nurse or a novice nurse looking for a way to organize and streamline your report giving skills, this video is for you. So let's talk about a nursing report. It's probably one of the most important tasks that a nurse is going to do throughout her 12-hour shift or his 12-hour shift. It is basically the synopsis or story about your patient and about your day. And basically we do it when we are ending our shift or when we're transferring a patient from facility to facility or from different floors. So basically at the end of your care of this patient, you are required to provide the nurse that's going to be taking over with a brief report or story about your patient and your day. And so how exactly do we give this report? Well, I'm basically going to tell you how I do it. Every nurse has their own style, but this is something that has worked for me throughout the 10 years of my nursing career, and I just wanted to share it with you in hopes that it might be of benefit to you. This video is actually going to be a part of a series of report giving videos that I'm going to shoot. This first one is going to be a brief outline on how I basically structure my report, and then the subsequent videos will be more in detail on what to talk about in each section. So without further ado, let's get started. When I start my report, I like to go ahead and first name my patient. A lot of times I will write it down by hand, but you can also use one of those MAR or electronic medical record stickers that they have in your chart and just slap that on there. And usually it has the name of the patient, their doctor's name, and their age. Some hospital facilities do not allow you to use your sticker as your report. The hospital that I was working at allowed me to do so. We were just not allowed to use the barcode to scan medications. And so this allowed me to get the patient's full name spelled out properly the way that it's supposed to be spelled. Their age and their doctor's name was already provided on that sticker, and so it made life a little bit easier. If you do not have the ability to use these stickers, just go ahead and handwrite the information on your report sheet. Once I'm done with that, I like to go ahead and jump into a few little details that may be of importance or are of importance. One of them being the code status of the patient. I like to discuss this in report, number one, because it's important. Number two, because it allows the nurse that's going to take over your patient to have very pertinent information at his or her fingertips. A lot of times things go really crazy in the ICU or in critical care, and you need to know what your patient's code status is right away. Having it written down in the report sheet is a good way of doing this. That being said, I do encourage the looking over at the actual chart as you're giving report. So basically, if you are saying that your patient is a full code and you open up the chart while you're giving your co-nurse report, and for some reason the doctor has modified their code status, you would be able to check yourself. It's kind of like a checks and balances system. So you would be able to see that there was a change that was made. So go ahead and always, when you're giving information in the report, you want to back it up with things that are actually physically documented within the electronic medical record or the regular medical record that the patient may have if you are not at a facility that is using electronic medical records. If your patient happens to be a patient that is a category 2 or a modified code status, which I know a lot of hospitals are doing away with, but if you're working at a facility that still does use modified codes, it's very important for you to provide the information to this oncoming nurse as to why this patient is a modified code. What I mean by that is, what exactly are we allowed to do or not allowed to do in order to resuscitate the patient that you're giving a report on? This just, like I said, allows the nurse to have that information on hand right away in case of an emergency. And then I like to talk about the patient's allergies. Of course, these are very important. I don't really have to explain why, but in case you're wondering, we don't want to cause your patient to have any kind of allergic reaction to any medication or any food that you're going to be giving your patient during your 12-hour shift. Once that's done, you want to go ahead and jump into your patient's reason for coming into this hospital. So I generally like to start it off with my patient's chief complaint. You want to talk about like why exactly this particular patient came to the hospital. And this usually is, in their own words, the reason for coming into the hospital, be it a headache or leg pain or whatever it is. And then you want to talk about the actual medical diagnosis provided by the physician that assessed this patient in the emergency room, or the physician that had seen the patient once the patient was admitted into the hospital. Once that is taken care of, you want to jump into the medical history. You want to talk about any past medical history that the patient may have. If your patient happens to be from a nursing facility and they are unable to talk for whatever reason, be it having an ET2, dementia, or whatever, there's a slew of reasons as to why a patient would not be able to speak, and they don't have any family at the bedside, you can find the information about their past medical history in the packet that is sent to you from the nursing facility. Usually the doctors taking care of the patients in nursing facilities have this information written down in an H&P that they hand off to the ambulance who brings the patient to you. Once I'm done with that, I like to go ahead and jump into the meat of the story. And this is basically my head to toe assessment. Before I get started with this, I just want to talk about something that kind of like gets me a little bit when I'm getting report. When you get report from a nurse who is not utilizing the head to toe method when giving report, it really kind of throws you off. A lot of times very pertinent information can be lost. You know, if the nurse is talking about the cardio system and then jumps down to like the GI system and then goes back to the neuro system, it really makes for a jumbled report and it's very hard to pay attention to. So if you're a new grad nurse or if you're a new nurse, I would really advise you to start getting into the habit of using the head to toe method when giving report. And so if we're doing that, we're going to start with the neuro system. We're going to talk about everything that has to do with the head, the brain, the eyes, the mouth, you know, the face, everything. But also the neuro system includes everything in the neuro system, including your spinal cord and the ability to move and speak. So you want to address those things when you are addressing the neuro system. Then you want to talk about the cardio system. Cardio system would include vital signs, any kind of medications that are utilized to affect these vital signs, whether it be to increase your blood pressure or decrease your blood pressure, depending on your patient. And if you are working in a unit like the ICU or critical care where your patient is being monitored on a cardiac monitor, you want to talk about their cardiac rhythm and things like that, and any modifications to that with drugs or just physiologically. Then once you're done with that, you want to go ahead and jump into the respiratory system. When talking about the respiratory system, I like to talk about my lung sounds. I like to talk about any form of oxygen delivery, be it a nasal cannula or ventilator. What exactly am I using to give my patient oxygen? How much oxygen am I giving my patient? And what vent settings if the patient is on a ventilator. Once I'm done with that, I like to go ahead and jump into the GI and GU system. And basically what I want to talk about in here is what my patient is eating, how they're avoiding, what their bowel sounds are, what their last bowel movement was. Again, this is the watered down version. I will be having subsequent videos talking in detail as to what we should talk about in each section. So once the GI system is done being spoken about, we want to go ahead and not forget about the skin. I say not forget because the skin is very often forgotten. We seem to forget about this very large organ of our body. Do not forget it. Go ahead and talk about like any wounds your patient may have, incisions, and any care that the patient is receiving, be it wound care or dressing changes or anything like that, you want to talk about in the skin section. So once the head to toe assessment is basically completed, you want to go ahead and talk about the miscellaneous things, which aren't actually super miscellaneous. They're very important. You want to talk about your IV lines or lines and drains. So if your patient has any Foley catheter or any kind of drainage system, maybe it's a rectal tube, whatever, you want to talk about then. You also want to talk about any lines that are going intravenously, IV lines, PICC lines, central lines, A lines. You want to talk about portacaths, AV grafts, AV shunts, whatever it is, all of those kind of things, you want to talk about it there, when their last dressing changes were, whether they're working properly, and if there's any medication going through any of those IV lines, you would discuss it at this point. Once that is taken care of, I like to go ahead and talk about my labs. Now, labs is something that I'm not going to go ahead and discuss fully in detail. Like, I'm not going to sit there and dictate to you or the nurse that's getting a report from me every single lab value or every chemistry panel or CBC or anything like that. Basically, all I'm going to do is I'm going to talk about the ones that are abnormal. So you want to talk about the abnormal labs and then maybe talk about like what you did to fix them or what measures were taken to replace like the electrolytes or anything like that, or if you gave blood or anything. And then, you know, once you're taking care of that, you can go ahead and jump into the plan section. The plan section, I call it the plan section, but really this is like the actual miscellaneous section. So I will talk about the plan of care for my patient, any kind of lab values or procedures or tests or anything like that that we plan on performing on this patient within their hospital stay, whether they are going to be transferred or discharged, or you know, just basically anything that's going to happen to this patient after today, or anything that they need to look out for, or the nurse needs to look out for. Once that's taken care of, I like to use it as story time. Anything that happened during your day in the hospital today, your 12-hour shift, anything that happened that doesn't necessarily fall within the physical assessment, the diagnosis, the history, or anything like that. Maybe it was an interaction that you had with your patient, maybe an interaction that you had with the family member, maybe you learned that your patient had like substance abuse problems and you contacted social services. Whatever it may be, you can discuss it in this section. And then I also like to go ahead and include in this section the next of kin's phone number. So when I say next of kin, I mean the person that's responsible for making decisions on your patient's behalf when they cannot do so. And this could be like a legal DPOA, it can be the wife or the child, whoever the patient has appointed to care for them in the case that they cannot. You want to provide this number for the nurse that's going to be taking care of this patient. Again, when things are going crazy in ICU or in critical care, it is very difficult to open up the chart and look. It kind of wastes a little bit of time. Now, if you're going to go ahead and give that phone number and check it with the actual chart, this gives the nurse a tool. Now, if she cannot make the phone call, or if he cannot make the phone call to his patient's family, he can go ahead and delegate this task to a co-nurse and be like, hey, my patient is crashing. Can you please call his daughter and tell her to come here as soon as she can? So then like it kind of takes the burden off his or her shoulders. And so I like to include that information in there. Now, once I'm done talking about all of this, I go ahead and list off the doctors that are responsible for the care of this patient. I like to do this at the end of everything. And basically the reason why I like to do it is because now the nurse that's getting report already knows all the issues that your patient has, all the medical diagnoses and stuff like that. And so they're able to kind of like correlate like medical diagnosis with physician. It's just the way that I like to do it. You're welcome to do it any which way that you want. If you go ahead and practice these skills, you're going to get a lot better. The more you give report, the more you practice giving a organized report, the better you're going to get at it, the more respected you're going to get as a nurse. And eventually you're not going to need a report sheet, and you're just going to be able to remember everything about your patient and just say what you need to say in report without being nervous or anything like that. But if you do need a report sheet, I will be including a link down below that is basically a link to my nursing brain. It's something that I have used from day one in my nursing career. It was something that my preceptor had given me when I started with him on day one, and I kept it with me and I modified it throughout the years, and it has served me well. I've shared it with my nursing students. I've shared it with the students that I've precepted. My colleagues, the nurses that I've trained into the ICU, and everybody seems to like it and they modify it to the way that they like. And so you're welcome to it. It's free of charge. You can go ahead and download it, modify it as you will, share it with your friends, whatever it is that you need to. But if you're going to go ahead and share it on an online platform, all I ask is that you link it back to me. And yeah, so I hope this video helped you. Stay tuned for the ones that are going to follow. If you like this video, go ahead and hit the like button. If you want to see more videos like this, go ahead and hit the subscribe button. And if you have any questions at all about this video or anything else nursing related, leave me a comment down below and I'll be sure to get back to you as soon as I can. Bye.